Good morning from all around the world, and welcome to Structural Heart Life Cases, broadcasting directly from the Cardiac Catheterization Laboratory at the Mount Sinai Fuster Heart Hospital in New York City. My name is Pedro Moreno. I'm an interventional cardiologist, a professor of medicine, and I will be your moderator today. We'd love to hear from you, so please send us your questions either at the website or on YouTube. And remember, all our previous structural heart cases are available for your review at ccclivecases.org. And now let me transfer you to the cath lab for this interesting case.
All right. Good morning, Pedro, and of course, welcome our audience of the CCC Live, the global audience, and our structural, the audience is also increasing at a slow pace, but definitely increasing. And we are trying to bring the latest topics, sometimes showing our own, I would say, issues, complications, or learning. And that's the whole purpose is with myself, Dr. Keeney, and Dr. Tang. Three all today, Dr. Khera, and we are two fellows actually. It started with a 3 to 4 hour structural fellows with Santosh and Pratish. So with that note, we are going to show this case, which you will say that why are we showing it? It's just basically to learn things. This is supported by our usual, and start with the faculty involved here, with the cardiac anesthesiologist Spencer Laurent. And the case is very interesting. It's a redo TAVR for PVL of Evolut FX Plus using SAPIEN-3 Ultra Resilia. I said, what is new about it? We have shown so many cases. Well, we have not shown the case because this case was done in March of this year. We did the TAVR valve using 29 millimeter Evolut FX Plus, post-dilated. Had a PVL post-dilated with a 24-25. I'll show those angiogram, and left with a mild PVL within 2-3 months, became severe. And that basically the case all about. Also as a CAD, patient symptoms, so we did a PCI of the circumflex, but most important is that patient has a acute valve, I would say, deterioration. So this by definition will be non-structural because it's a PVL. Structural valve deterioration is the leaflet issues and the valve. And so non-valve is called non-structural deterioration, and that will be the focus of our discussion today. And the valve is working perfect. Effective orifice is 2 centimeters. So, that's a great, with a minimal gradient. And so the key is the patient had developed severe paravalvular leak, which was mild. Patient does have some various issues, which you can see, HIV positive on good medical therapy from that point of view, but continues to be symptomatic in last March. So I'll leave it here. They're starting with the index TAVR. At that time, nothing unusual, like a run-of-the-mill case. Because of CAD, we felt it will be a good case for Evolut 29, and that is what done. And maybe Gilbert can comment on it. So what was unusual on that day? That we went ahead, it was a PVL++, then dilated with a 24 millimeter true, then 25 millimeter ZMED2, and left with a mild PVL, which was significant decrease.
Go back to the CT.
Go back to the CT for a moment. So you can see that this patient also has severe MAC as well on top of that. And you can see that MAC extends to the annular and LVOT calcium that you can see in the orange triangle. So the valve is appropriately sized for the 29 Evolut. You can see the smaller LVOT. You could argue that you could put a 26 SAPIEN there too, but obviously the rupture risk will be very high, especially with this kind of severe annular and LVOT calcification. And of course, that is the concern. And you can see the hockey puck view. It's extremely calcified native valve extending to the mitral annular calcification as well.
And therefore, using the self-expanding at that time was the right approach. That's what we teach. And
I think most people would pick the self-expanding valve for the concern of aortic root injury and rupture.
No, I think with an understanding that you will have PVL.
Correct.
I mean, this case with nodular calcification, you cannot avoid PVL at all.
That's right, and this was clearly explained to the patient that, obviously surgical AVR in this case would probably, ideal because you can take out all those calcium. But if it's for TAVR, there's a trade-off between any commercial devices. Balloon expandable would run the risk of rupture, and self-expandable run the risk of PVL.
I know you wanted to say any point on that?
My question is subsequently, means we are seeing this often, that when do you think, no, okay, we are seeing PVL, right? So during the procedure, we are doing it, and then subsequently, probably there is a recoil of the valve, both of the SAPIEN as well as the self-expanding valve. So then when you see the PVL, when one is echo criteria, right? When you're seeing them at 30 days and subsequently, what are the other criteria that you're going to use?
So
To
let's
say
ask
yes.
Stem Larakas who is on the echo side, that because let's say you left it with a mild PVL, I mean, anytime it's a little more than mild, will not come out of the room. So just to say, overall, we have the TVT data that valve intervention in the country in 1 year is about 0.6%. At Sinai, that number is between 0 to 0.2% every year, 4-quarter changes. So it's not that we have seen much, but we did see some rare cases. Second then is the moderate plus PVL. So overall incidence of moderate plus PVL in the TVT registry is about 2.2, and in our cases is 0.6. So it's 1/3. So it does happen, but we sometimes just leave it.
Before we ask Larakas, let's finish. So when you are placing this self-expanding, does the depth matter? In this patient, we had calcium, right, at the level of the annulus, leaflet, and LVOT.
Yeah.
How do you get the depth so that the skirt, maybe if you we have to understand where to place the valve so the skirt can take care of the PVL.
I think it's a very good question, Dr. Kinney. The only issue is you have enough skirting up to 10 to 13 millimeters to actually cover the annulus. The issue arises is there's a lot of external calcification on the leaflets as well. If you see, the leaflets have very heavy calcification in addition to annular and LVOT. So your stent frame may or may not fully circumvent the entire annulus. It may be areas where the annulus is abutting and you have leak around it. So even though your depth may be perfect, your skirt is where it should be, but because of this external features, which is the calcification, you may not have adequate sealing. And we've seen it with self-expanding platforms, this one as well as the other platform.
Yeah, that's also important. Dr. Kinney got a very important point. Not all valves are the same type of sealing skirt. So the Evolut is actually a wrap. Okay, so a wrap with pericardial wrap. The SAPIEN-3 Ultra, it's a carpet, like, covering a skirt. So the friction, the fabric with the kind of carpet prevents the PVL by filling the crevices. The Navitor is actually an active skirt, which is like almost like a parachute. And it opens up in the diastole to try to trap the PVL. So every valve is a little bit different. So I think we need to understand that as well, beyond what Sahil also mentioned about the depth of implant, to your point. So obviously you don't want to be too deep or too high, as you mentioned before. But also there's a limitation what the radial force can do against very hostile calcified anatomy, and that's what Dr. Sharma's point is, that, and to your point, that these valves, like a coronary stent, can recoil because these are nitinol stents, nitinol frame, and they have a memory. Even with the cobalt chromium frame of the SAPIEN valve, it also can recoil because you have to counter against the radial force versus the native anatomy resistance.
Yeah. So two things, right? One, maybe you have to change the way the skirt is, like
Correct.
you're saying.
Yes.
Not parachute, maybe instead of the skirt, we need a gown.
Yes.
So it actually
A cape.
So it actually goes underneath covers. That's number one. Number two, like we do so much calcium modification of coronary arteries, we got to start doing calcium modification.
Yeah, that's a good
right?
idea.
Of the aortic valve, and then place the.
That's a very
That's
great
a good
point,
idea.
Dr. Kinney.
That's a good idea. Yeah.
Go ahead, Stem.
Yeah, that's a great idea that Dr. Kinney is bringing up. But I think in this case, most the PVL, if you see, is exactly where the calcium is. Exactly where the calcium is. So I think the PVL in this case is for two reasons. One is the calcium, and then is the recoil of the valve. So
I mean, they are startup companies working on shock wave, lithotripsy of the aortic valve calcification. But that's still very early in humans' experience.
Now, there's still the question from Dr. Kinney to Stam, and the audience is important. What are the criteria that you use on the echo?
I will show you on the case.
Shall we show
on
now?
this case, if you like, I can show you But
Yeah.
as you know, there are many criteria, and you have to put all together. The main
Show
criteria.
us on the case live. So
Live.
one echo criteria, two non-echo criteria.
Yeah,
So this is what happens. We are seeing the patients in the office. Now we have to talk to the family and the referring. And you tell them you need another procedure. You know, you got to be 100% sure why are we taking the patient back into the room.
You like me to go through all the echo?
Yeah. Let's do the echo now, Stam.
Yeah,
Because
so basically,
the presentation will match what you
So
show
see,
actually.
Yes. So basically, this is a deep gastric view. The patient has normal LV function, dilated ventricle, some LVH, no pericardial effusion. This is the right ventricle here, is normal, no much tricuspid regurgitation. This is the mitral valve as previous is circumferential calcium all around. This is a 3D image of all the calcium around the mitral valve, mild to moderate mitral regurgitation. The mean gradient is 6, severe mitral stenosis because of severe calcification. No pulmonary regurgitation, no thrombus on the left lateral appendage. And as you can see, as Dr. Sharma said, there is no degeneration of the Evolut valve. You can see the leaflets moving nicely, but you can get the feeling up to near the mitral cortin that the valve is recoiled. There's a space that actually you can see between the anterior leaflet and the valve frame, and also there is a lot of calcium there. And if you can see the next image, that's where the paravalvular leak, severe paravalvular leak by this view, and you can measure the vena contracta is one way to measure the severity. This is the short axis, and what is used mostly is the short axis, as you can see here, is between the native commissure of the no coronary cusp and the left coronary cusp. That's where the most of the PVL is coming. And this is the criteria that is used. We basically trace the PVL, and as you can see here, we trace the PVL, and then we trace the frame of the valve. And the ratio, if it's less than 10, is mild, 10 to 30 is moderate, and more than 30 is severe. Here we got 25%, which is close to 30, you know, so it's moderate to severe if you put everything together. And this is a deep gastric view. Again, you can see significant PVL, and you can see the PVL is exactly where the calcium it is coming. And we measure the pressure half time comes to 284, below 250 is severe. So it's we can call it moderate to severe, but by color looks severe. And as Dr. Sharma said, there is no problem with the valve. The mean gradient is 4, peak gradient of 8, and the valve area is 2.6 that we get. And this is the annulus that we measure by 3D, which comes to 8.26 centimeter perimeter and close to 5 centimeter square of the area, the same almost that they got with CT. So basically, the most criteria that we use for PVL measurement is what I show you, the ratio of the PVL that you measure, the maximal PVL area compared to the frame of the valve. And if you have multiple PVLs, because sometimes you can have more than one, then you measure all the areas and you get the frame, you get the ratio. And again, if it's less than 10, mild, more than 30 is severe. So this case, everything is close to moderate to severe, you know. So looks severe.
Okay. So clearly the question then come back at the time 0, we still have a PVL. Was mild, was never minimal or 0, could 1 plug at that time or follow up, and we'll ask Sahil on that. Or second, could we have done second valve at that time, knowing that PVL, now diastolic pressure, we got it, the diastolic pressure was okay, was not low in that particular case. So question is second valve at that time to remove that or eliminate that PVL completely, and secondly, should we plug them? Yeah.
So, I'll be devil's advocate here. I think 95% of our TAVRs are done in max sedation with TTE. So first of all, quantification of TTE PVL is very different from a TE PVL. So at time 0, when we are doing these procedures, we do a balloon post-dilatation. The PVL almost always on a transthoracic echo looks to be improved. So at that point, pushing for a second valve immediately in the room just makes it harder. trying to plug core valves SS is very hard because unless you have very generous sinuses, trying to plug core valves is extremely hard. So most of these patients, they may have more than mild, and we are probably underestimating PVLs at this point. But because we do TT only procedures, we're not doing TE only procedures, it just makes quantification very hard.
Yeah, I mean, I would say that, you know, a TTE will not miss this kind of PVL, So, I mean, I think it was, I saw the images, and after
it became mild. No, I know, but it was not zero. No, what I meant is, it was not zero, it was mild, even on that day. The question was, could we have gone with a 26 true balloon?
Well,
we did a 24 true, then ZMAT 25 is still mild. Could we have gone with a 26 true?
I mean, you can. I think the risk will be root injury, just like you would do the 26 SAPIEN to start with. I mean, it's a trade-off. Like I said, you have to, it's a 26 a non-compliant balloon. You cannot see the pressure. So you would have to see and probably do it under TEE to make sure the root is not being stretched to reduce. But either way, remember, nitinol frame is not a copochromium frame.
Yeah.
Nitinol frame will recoil. It's a memory, so it conforms to native anatomy. Whatever you can stretch beyond, it'll come back. It'll be reduced. So
Now question, where are you going to place this second valve?
So there are two things actually.
Want to show the slides?
One's a size, because now we're thinking maybe we should do 26 minus instead of 23 because the native anatomy is 26.
Yeah.
That was the question we
So
had
the
this
second
morning.
question is the positioning, like you said. So so you can see on the echo here that it corresponds to the CT, which is coming up next.
Which is clear-cut gap.
Yeah. So you can see this is the.
So now we did a
PCI.
SIR PCI, which is separate here. This is a CT of the redo tower.
So you can
large
see,
gap.
So you can see there's a gap where the orange triangle is. That's where the source of the PVL is. And so if you look at the next slide, so in vivo sizing would be roughly, if the valve is grossly underexpanded, right? The native anatomy is 516. Now we're talking about 378. So the question is, should we do a 23 plus or 26 minus because it's PVL? And looking back at the native anatomy, I'm thinking maybe even a 26 minus would be better because 23 plus, you might still have a gap.
Go back.
So even though the in vivo sizing with the app may tell you that it's 23, maybe for PVL it's not the case. It's maybe you need to upsize. So this is something that we're going to bring the 26 valve system also to consider this.
Now, to me, if this is what your CT you're telling me,
Yes.
second valve is not going to do anything. You need to plug it.
Why?
Yeah.
Look where your there's a gap. Okay, but first of all, it's not circular, almost. And there's a gap. That gap cannot be sealed with your second valve.
No, but if it is below,
So
Slightly below the
this
flat.
valve is very underexpanded. Remember, the inflow, this is a 29 Evolut. So the inflow would be 29 if you take it out of the shelf. So the question is, will the second valve will expand the Evolut to closer and conform and close that
Is
gap?
that-
And I think a 26, what do you think, Sahil, would
Okay,
be,
we'll do
would be
26 in the morning
would-
board rounds. We
yeah.
discussed it should be 26. That's
would be,
one.
would be better to because 23 is going to be limited by that.
and with the which node, at what level?
So
No, that
this,
we will go
this is
with.
paravalvular leak, so we can do it at
No.
no 4, and that should be you just want to seal the inflow.
Yeah.
Yeah. So we're going to bring the 26 system in here as well with
And
the
then
26
you
valve.
think the skirt of because the SAPIEN skirt,
No, the SAPIEN skirt won't do anything. It's the
Yes.
Evolut to the
its
radial
Evolut
force.
skirt has to be active. I hope it's still
The wrap has to be active. So
Okay.
Yeah, my only concern is the minor axis on your native
Yeah.
CT is 22.
yeah.
So, we have seen cases where post-dilatation of a core valve has ruptured annuluses.
Yeah.
So,
Open.
and the other thing is you have a larger valve to reinforce, which is going to be a 26 minus some volume. There is a risk of early degeneration because of pin beating.
Yeah.
So you will not have a fully expanded redo TAVR valve. That's another thing to think about. So,
Yeah.
I mean, the jury is divided. I
Yeah.
could go either way here.
Initially, we were thinking 23, but today we're deciding 26.
Well, we're still deciding. That's why we want to let the audience know if it's a prosthetic stenosis here, there's no question it's going to be a 23 plus.
Right.
But this is paravalvular leak. We don't see that much. All the redo TAVR people talk about in conferences are structural valve deterioration.
Yep.
Longer term degeneration. This is more acute within 1 year, within 6 months. And the mechanism PVL. So that's why I think we are agnostic. So I think we should have a discussion. There is a trade-off again, like you said, with even like the index TAVR, right? Versus self-expanding versus balloon expandable. This is going to be also a potential trade-off between two different sizes. Larger size will get better radial force and seal, but does run the risk potential injury. Smaller size you might not seal, but you'll be safer.
But this we have to seal it. I mean, remember it was so tough to convince these patients when they come back and tell them soon that you may need another valve. I can tell you the patients
I'm saying plug it.
Very angry. Very angry.
So I think, Sahil, what do you think? 26 minus or 23 plus? I think that's.
You want the valve? You have to go 26.
26, yeah,
But
26.
I'm telling you, even then, if you need something, we need
26.
But can the plug create a trouble for the coronaries? Because this patient also has CAD issue.
So we have pictures.
Yeah, let's show the aortogram here.
Yeah, let's go to the angio.
PVL. Where is the PVL? Closer to the left main?
Left,
right?
left.
Yeah.
It's commissure to no coronary to the left. Yeah. Next to the left.
So the
main.
sinuses are very big. So sinuses are very big.
You have enough clearance here.
Yeah.
You can see. So the plug will probably sit somewhere.
Go 26. 26. 26. Minus 1.
I suggest 26 placed close to the LVOT, closer.
So the other interesting thing is that we always not just look at the CT but the aortogram. Is that if we actually did some views for the audience. So this is perfect. So this is the kind of cusp overlap. Remember FX plus as the open cells. So on the right side see the open cells, and this usually mimics the short axis of the anatomy. And you can see this is a 29 Evolut, and it's not really scrunched up as much as you see on CT. So that's, the question is that whether 23 will expand enough to seal against the anatomy versus a 26.
No.
So I think based on this, based on echo, and based on fluoro, I think for PVL reason, I think the audience need to be very clear. This is not for prosthetic degeneration. I think a 26 volume out would seal better with the radial force than a 23.
Yep.
If it's prosthetic AS, then it's a 23, right, Stan?
Yeah, agree. Yeah. This is for to seal the.
If it's pure AR, you can still do 23 plus, but you have to put it in the right spot.
Like for sure 26. Yeah, for sure 26. Yeah.
And just to say that we have a very nice commissural alignment and coronary engagement was very good.
Yes.
When I did the circ PCI, and of course now you saw that how good the engagement has been, and with the right coronary. So really FX plus worked.
Yeah, FX plus work, and this one has a really perfect alignment for commissural on the confirm on the CT scan.
Okay. Tell us, AK, what you're doing now.
I'm trying to cross the valve. First use the pigtail.
Any questions from the audience, Dr. Moreno?
No, but very important the discussion that the valve has to be below the paravalvular leak, and then we have MS, severe MS. So why don't you expand on that situation?
Apollo.
So the MS, so the Apollo right now needs to be at least moderate MR for MAC. So we have after 90 days for Apollo trial, and also have to make sure that LVOT is not an issue. So as you know, Tendyne is approved now for valve in MAC, but it's transapical, and so that's another option for this patient. Once we have the device available. So we will do this first, and then we will reassess you probably 30 days afterwards to see, in terms of evaluating for a, Tendyne in MAC, probably the most realistic, or the Apollo trial.
Okay. And see that no gradient. You see the hemodynamic just 5 millimeter, what was on the echo. We knew, and valve area actually was 2 plus.
2.6.
2.6. 2.6.
So one question just came up from Dr. Mohammed Ali.
Yeah.
Mohammed Ali, he says, why not PVL closure? And can you show the CT where the defect is? I mean, we already did that. Left sinus is big. That's his whole discussion about the PVL closure versus the new valve, and we already went through it.
Yeah.
Yeah, that's a great question, and I think I already answered. If the sinuses are generous, you can close it.
Show the slides again, yeah.
The only issue is you have 4 areas of nodular calcification. So I think first trying to reinforce the valve frame with a redo, if we can get it done. If not, then we'll think about closure.
He probably just joined.
Yeah, this is the
Yeah,
key.
here. No, here.
So what Sam looked at on echo, and here is no 1 and no 2 on this particular image. You see on the 6 o'clock area, there's a gap. And the valve is not circular. And remember, this is a 29 Evolut valve. The no 1, no 2 are grossly underexpanded. It's only around 23, 24. So that's where the calcium is impinging, impeding the frame from expanding more optimally. And so the only way we can do that is to put a balloon expandable valve there for the radial strain. You cannot put a self-expanding valve to increase the radial flow. People used to try that, but it's not really going to do anything any good. Not to mention that you cannot, remember, overlap the cells perfectly. So this patient has PCI before, so coronary access is extremely difficult with a tall and tall kind of combination. This one, the only way to use it is the balloon expandable platform to allow us to be able to hopefully increase the expansion of the Evolut valve against the calcium and native anatomy. Beyond that, there's really no other solution. To your point about paravalvular leak closure, this is a tall valve. Thank goodness you have a big cell for FX Plus to go through, but you still need to be able to rail through the biggest spot. And sometimes it's multiple spots. So I think that would be the next step to be considered at.
And you're doing
So I am going to pre-dilate this. We need to pre-dilate because remember the stent frame is very underexpanded.
Yes.
So we'll use a 25 true balloon here.
I thought we said frame was.
It's underexpanded and recoiled, yeah.
No, CT.
Hold the wire.
Okay, what size balloon is this?
25 true.
25. Go down.
We did use 25 last time, but it was ZMAD.
Yeah. Base 180. Go all the way. Good. Yes.
Okay, look at that calcium.
Yeah.
Then what?
Back up pacing. Thank you. Valve. 1 second.
Show the frame wise whether frame expanded with this balloon.
It did.
It did.
Cine, at the end of the cine, you could see that.
See if we-
Stam, how does it look now?
Yeah, let me see.
Greater more AI.
No. Remember, the valve itself is normal
I
to
see.
start with.
No, dash
So
has become very low.
yeah, the question is that whether PVL, improves. Now, having said that, you're right, Dr. Sharma, that the IFU for 29 Evolut is 23 millimeters the weight, up to 24 true.
What is it,
This is
26?
25 true, so obviously there's the run the risk of.
Yeah, you can. I don't know if you want to put it live, but
Yeah, we
it's
see
live
it.
now.
We see it.
yes, yeah.
PVL
It's,
there, you
that's now is still,
It's definitely lower,
a little bit
but
less,
still
but
moderate
still,
severe, yeah?
Still, you see the space. You see the space.
Yeah.
You have the
Yeah.
plug ready?
Like that.
Let's
yeah.
see. Let's see how it looks.
Okay,
And change.
I got wire.
Okay, advance.
Zoom in.
Yep. Tee up, please, Stan.
Let me do
Sorry.
yeah.
Where's the pigtail?
It should be okay.
You don't need the
You can do
picture
it, yeah. You can do one picture if you want. But
So you can see the big cell of the Evolut. You can count. We're going to aim for node 4. We don't want to aim too high.
Okay, there.
Although the 26 will fall short and less. So that we'll keep that in mind as well.
That's okay. Okay.
Okay. Picture. Okay, 180. We have to pull back up.
No, we don't want to be too.
It's too low.
Okay. Off.
Off.
It's too high.
Okay,
It's too
looks
high.
good there. I would not
That's
go
what I
higher.
said. Huh? High?
Don't go higher.
Don't go higher. Yeah.
Yeah.
Too high actually.
Okay. 180.
Cynator deployment.
Cynator deployment.
Slow.
Cynator deployment. Yes.
7, 8.
7.
Okay.
No, 6.
6. Okay. Keep pacing. Keep pacing.
Keep pacing.
Okay.
Back up.
Back up pacing. Good. I want to do one more inflation stamp before you do anything.
Yeah, I would add 1 cc. Go nominal.
Go to nominal. Take a picture here, please.
No. Do that, no?
Pressure is good. Pressure is good. So we're not. So the first thing we worry is about annular injury, but the fact the pressure is good, that's a good sign, right? Your patient is not hypotensive. You want to aortogram first?
Yeah.
Ready?
Yeah.
Better already. Okay, good.
PVL looks better already.
All right. So, ready?
So we added one more, means it became nominal 26.
26 nominal.
Yes,
Yeah.
yes.
True size to the native annulus.
Yeah.
Okay, ready. Ready?
Yep.
180.
Lungs down.
Go.
Okay, going up. Okay, now I'm 7.
Get the pigtail ready. Although it doesn't matter, there was no gradient to begin with.
Okay.
Keep pacing. Okay, back up. Flex off.
We still want to do hemodynamics.
Yes. Oh.
Yeah, let's do
We don't need
hemodynamics.
hemo.
No, we
We
want to
still
say
should,
that they were not created a gradient.
Yeah. Give me a pigtail next.
Gradient? Where? Oh, you mean?
LV.
Stam, you can check now.
Check.
You got wire?
Yeah.
See the, I open the, okay, put color.
Look at that.
Still there, but better.
Mild, yeah.
I mean, even if we start with a 26S3, originally this would be kind of our expected result, right? Because the calcium, you don't want rupture either. So, and at the end of the day, you know, you cannot fight calcium. Stan, what are your initial thoughts?
Yeah.
In terms of the severity?
Show your short axis, Stam, where you did all those area measurements.
Yeah. Okay. Sort single.
And continue to show the hemodynamics also.
Stam, definitely much better.
Much better for sure.
Much better, yeah. Look at that.
Also, fluoroscopically, it looks better. So let's show the audience while we replay. This is the initial same view, okay? So this is the same view. You can see there's a waist of the Evolut with the 29.
Yep.
So now we did the 25 through, so you can clearly the waist, it's expanded, okay, with the inflow.
You go.
Okay, so now you can see there's a little bit of recoil.
Yeah.
Okay, so this before, and Dr. Kinney simulated the deployment, and you can see how much expanded. Look at the inflow frame.
Single frame.
Okay.
Single.
And then finally, this is the, and then this is the pulse, which is even bigger.
Bilirubin.
So this is nominal now.
Yeah. No hemolysis.
Now on CT, we have seen that these valves are not 26. Okay, so we just published a paper in JACC intervention, looking at 30 patients with post CT after redo TAVR, and these will be underexpanded. But this is the purpose of this is to reduce the PVL. So obviously we need to follow these patients long term in terms of the hemodynamic performance of the valve.
Okay.
So, Stam, on short axis, remember you showed us some area measurements?
I'm trying to do now.
Can you show us that same area measurement so we can assess pre and post quantitatively?
And how does the AR index look on the hemodynamics? We should probably show that as well.
No, bring it down. Bring it towards here. Towards me, Prof. Towards me. Yeah. Okay.
So from the audience, they said they look still at least moderate.
Okay.
but it's probably
Yeah,
because
measure
of a focal calcium rather than an expansion issue.
Yeah. Also, our systolic pressure on the hemodynamic is 160, 170.
Okay. How much
So it's
Yeah,
quite
I think
elevated.
it's
0.4 and now
mild
measure this
in my
thing.
opinion, but
It's
let's
quite
see what
elevated.
quantification is.
Yeah.
So,
0.4.
so
0.4 divided by.
can you do that? Can you show echo and hemo at the same time in fluoro? All three screens, please.
Yeah.
Yeah, 6.7, 0.4 divided by 6.7. How much?
0.4 divided by 6.7.
No, 0.4 divided by 6.7.
Are you using mental math or are you using a calculator?
Calculator.
Yeah.
Calculator give you
5%. 5%.
Yeah.
So you went from 20.
5%. All right, 25 down to 5.
If you did mental math, let's redo it
So,
again.
Okay, let's
so
go.
I
Let's
think
go.
it's very important that we used
go.
a method to quantify early on, and I think we should use the same method as
But also
post.
we should do look at AR index as well, right? People still do that, you know, especially in paravalvular leak situation. What is it? How does it show the hemodynamically?
Yeah, I don't think
doesn't look that bad on
your
the AR index, right?
diastolic pressures are actually better than your starting diastolic pressure. So to me, hemodynamically and from a quantification
End diastolic
standpoint,
pressure is 18, and
Push up, Prof.
the aortic diastolic pressure is 60.
So it's better than before?
Yeah.
yes.
Okay, Prof. Take it.
Stan, what is your quantification then?
I told you, mild.
Mild.
Mild, all right.
Take it.
Pedro Moreno.
Yes, I'm listening.
Yeah, this is like doing provisional stenting and then looking at the side branch.
Correct.
Do you want to do something or walk away? So that's what we are looking at right now.
All right, so let's go to our continued presentation. The case-wise, we have done a tremendous job with everybody's input, and we thank to our audience also keeping us on our toes, and that is what the discussion will be today. About the transcatheter valve degeneration, early TAVR failure, management of structural valve degeneration, and of course bioprosthetic valve degeneration, redo TAVR versus TAVR explant, TAVR valve durability, mid-frame underexpansion in self-expanding and patient prosthetic mismatch in the balloon expandable and early TAVR trial. So basically, we know that the various terminology which we talk about, structural valve degeneration, SVD, or non-structural valve degeneration, NSVD. So structural valve is your fibrosis, calcification, tear, detachment, and so, and of course others are thrombosis and endocarditis. Actually, the recoil, Gilbert, there's not much in the literature. There's not been, I will try to look into this aspect, the recoil of the valve, very they talk description, but not any methodical publication on the recoil issue.
No, because they don't typically do any CT scan, right? Unless there's indication for halt and other things. So, but we have now done double tap for quite some time now. We're writing up that paper, so we're showing that actually.
Okay. So these are the structural, and basically what we do is, once you the structural valve degeneration, there are hemodynamic stages. One is you just have a little bit of gradient and nothing, no symptoms. Second is stage 2, when the gradient is more than 10, or total gradient more than 20, or 1 plus regurgitation, or stage 3, which is a severe hemodynamic valve degeneration, where the gradient is more than 20, total gradient more than 30, and 2 plus regurgitation. And of course, then what you need to do is, if you have a mild, you leave it alone. Like this case would have been a mild PVL, we would have left it alone. But when progressive and symptoms, you bring them for the treatment. And of course, the various testings, whether it's the CMR, CT scan, and TE, those are the 3 important things which we use for various etiology of diagnosing various types of bioprosthetic valve dysfunction. And as we said, clearly once you have thrombosis and endocarditis, they don't do the TAVR, they go for surgery. Then in the structural valve degeneration or non-structural valve degeneration, severe PVL, like the case we have today. severe patient prosthetic mismatch, unless you want to fracture the valve, feasible, then only you will start TAVR. Otherwise, all these patients, or if there is a concern in the structural valve about the coronary issues and residual patient prosthetic mismatch, they all should go for surgery. And so then the early TAVR failure, which is like this case, which is less than 3 years, valve thrombosis or clinical or subclinical halt, cusp rupture and damage to aortic valve leaflet, both were excluded in this case. Accelerated calcification happens in radiation patients and hemodialysis. Endocarditis, valve migration, none of them were present except this patient has a valve recoil. Compression, inadequate expansion was the cause. Now, what we learn is that the bioprosthetic valve degeneration is not a simple disease, and it actually starts with the same what original process was of the calcification. The dystrophic calcification of the aortic valve starts with the inflammation and goes through the various stages that structural valve deterioration triggers and pathogenesis, current approach in the protect bioprosthetic valve calcification, and there's a lot of work being done that how can you prevent this bioprosthetic valve degeneration, particularly modifying the various leaflet issues and so. So as I mentioned, basically the process starts with the inflammation and dystrophic calcification with recruitment of the monocytes, and the start very early, and that part of the regular process, and this is where the various factors comes in along with the mechanical factor, that is the high output failure. So what happens to the native valve? Once you do the new TAVR valve, it is exposed to the same mechanism of the subsequent valve degeneration. And therefore, what is being done is on the 3 steps: mechanical stress, dystrophic calcification, and immune rejection. The key is the valve design. So mechanical stress in terms of various valve design, even using a polymer, so less stress. Second is efficient the anti-calcification treatment, dystrophic calcium, decellularization, and partly Resilia. Is that part, so making the valve durability longer. And then lastly, for immune point of view, biomaterial from the genetically engineered animals and immunosuppressive therapy, all are being tried to improve the long-term patency of the valve and decrease the structural valve degeneration. Now,
quick question for probably Sahil.
Yeah.
What was the AI index before and after? You can continue your presentation and Sahil can calculate that and come back.
It looks like it was a 0.25 before and now 0.4.
It's much better before, we can calculate it.
And then the key is which case get the redo TAVR, which can get a TAVR explant. We know that TAVR explant has associated higher mortality. We all know. And that you can see, but every case cannot go for redo TAVR. Redo TAVR basically is a TAVR explant is needed once you have the particularly patient prosthetic mismatch. You have PVL, you can do a redo TAVR. But if you have patient prosthetic mismatch, endocarditis, and so those cases are going to go for TAVR explant. And of course, we know that TAVR explant has a higher mortality, and redo TAVR, when they require, they usually take about 4 to 5 years. And the TAVR explant, usually those patients present earlier in the cycle, like 1 to 2 years, although this case was only few months. Then, as far as the durability of the valve concerned, we have enough papers now, which has looked into the structural valve deterioration and bioprosthetic valve dysfunction, and we have 10-year data from the NOTION trial with the self-expanding valve, earlier generation, identical outcome, and more importantly, bioprosthetic valve dysfunction was identical both after surgery as well as after TAVI. Then partner 2 trial also looked into that aspect, but they had 2 types in there. Remember, they have the SAPIEN XT and then became SAPIEN-3. And turns out to be the SAPIEN-3 outcomes were similar to the surgical valve in terms of the degeneration, whether it's a bioprosthetic valve failure or structural valve degeneration were identical in the newer generation of the self-expanding balloon expandable valve of the SAPIEN-3. Then partner 3 trial, we all know that 5-year outcomes again were identical, and But more importantly, if you take the individual valve-related issues, aortic valve, reintervention, endocarditis, valve thrombosis were identical between TAVR and surgery. So just to say that when the valve degeneration occurs, we know with the 5 to 10 year data now, in various our randomized clinical trial, the outcome, the type of the valve degeneration is similar between surgery and TAVR. Now this individual type of the bioprosthetic failure, 5 year about 3 to 4%, as you here, and it is where types, which is reintervention, valve-related death, and bioprosthetic
Go to other rooms.
valve deterioration were identical, whether it's a surgery or TAVR. Now, same data we have for the Evolut 5-year data. Outcomes are similar, as you can see there, and at the same time, from the bioprosthetic point of view, actually here, it looks like lower valve degeneration with the TAVR valve compared to the surgical valve. And so she seems to be at 5 years. The data for the balloon expandable, identical. Earlier data using in the Notion trial was identical with the surgery, but in the 5 year of the newer generation self-expanding seems to be a less structural valve deterioration compared to surgery at 5 years, 1.3 versus 5.8. Whether it's going to last longer in the 10-year data we need to see. Then the few of them, which is the crux of the case today.
Diagnostic. There
are enough data now which have come that maybe it's a valve-related problem when patients have the subsequent event. No, there are data from the Accurate Neo 2, which is a self-expanding mid-frame under-expansion. As you can see here on the left side, mid-frame under-expansion, once there's no under-expansion, the outcomes were dramatic. Compared to under-expansion, 38.6% and then event rate, once you have no under-expansion, was 3.6%. Post-dilatation, of course, will improve. The key is, when you're doing a self-expanding valve, make sure it is fully expanded, and we did in this case. As much as possible, we are able to do it, but it still remain mild. So self-expanding, full valve expansion is very important. Second, also paper, we have it from Raj Makkar's group, basically the prosthetic patient mismatch in a young and low risk after balloon expandable. And we also learned that once you have severe patient prosthetic mismatch or moderate, severe occurs in about 7%, moderate about 32%, and it is associated with outcome. Increased all-cause mortality, as well as increased heart failure hospitalization. And predictors are young age, the female, large body surface area, no balloon post dilatation, and a smaller annular size. So I think the second tap, maybe the one particularly in young people, will be able to decrease the patient prosthetic mismatch. Now, only question is that can you use or more so at the time zero to the bigger valve versus a smaller valve in these patients. So that's always a question to make.
Right, the issue is bigger valve. When we've seen that in previous paper, that it's underexpanded and a precursor for halt, right, and degeneration. So it's not necessarily better by putting a bigger valve in. We've also published that we actually put the smaller valve in, but better expanded actually has better frame expansion, more complete expansion, in fact, and no trade-off in hemodynamics at all.
Good. Now, we don't do it, but do we ever do a balloon expandable valve with the additional balloon material, means using the true ballooner? So we just use the...
We don't use the true balloon because that's the additional cost, right, associated with that. But some people have done it for mitral. So for mitral, they have done it to be able to get a better expansion because they worry about valve migration.
Very good. So then, just I want to complete with the early TAVR trial, which we all know, that remember the group was clinical surveillance versus early TAVR, and the clinical surveillance group were followed, and delayed valve replacement occurred in 80+% of cases in 388 of the 446. And what they found, basically, initial baseline characteristics were not different, but more importantly, once you got a delayed aortic valve replacement, event rate was 10.6 versus 6.8, and individual endpoints are here. So all of them, when you have a delayed aortic valve replacement in the clinical surveillance group, it is not good. And we know that majority of them, they called it 3 groups: asymptomatic, stable valve syndrome, progressive valve syndrome, and acute valve syndrome. So if you have any of those, when you follow these patients clinically, where you have a clinical surveillance, and they get into trouble. And we know that 5 years, over 95% will develop the valve will require the valve replacement, and clearly acute valve syndrome occurs in almost 1/3 of these cases. Once you develop acute valve syndrome, your event rate of death, stroke, hospitalization is 15% compared to 6-7% otherwise. So clearly, idea is, once you start patient severe aortic stenosis, the wait and watch policy does not help, better to replace it. So just to complete our take-home messages, one is the mid-term, mid to long-term, actually 5 to 10 years is a long-term, follow randomized trials comparing TAVR with SAVR in various AS groups have shown similar aortic valve degeneration, thrombosis, reintervention, and bioprosthetic valve failure. These data are very reassuring to establish TAVR as the comparable, definitive, safe, and effective treatment for most AS in patient more than 65 years of age, provided there is appropriate anatomy. But most of the data benefit was with the femoral. Then the possible mechanism of the structural valve degeneration and bioprosthetic valve failure are similar after TAVR and SAVR. Subsequent management largely depends on the etiology of the valve degeneration. Redo TAVR, which is preferred, but cannot be done in every case, but TAVR, explant, and surgery, higher mortality. One of the biggest things which is against redo TAVR is the coronary obstruction. That's the most important factor that we do not do redo TAVR is coronary obstruction. Anything new being done for that part?
No, I mean, leaflet modification is kind of the mainstream now, that if you have that concern, you should modify the leaflet. That's the safest way, because we know chimney stenting can even get crushed and kinked.
Valve under expansion after self-expanding TAVR is becoming a clinical entity and should be addressed at the time of the TAVR implant. And patient prosthetic mismatch plays a crucial role in determining long-term, so that importance of appropriate valve sizing is in pre-procedure planning and even post-dilatation if necessary. Then 5-year continuous medical surveillance, follow-up of asymptomatic severe patient showed high conversion to TAVR. At the same time, once you convert, there is a significant clinical deterioration and MACE rates are high. So therefore, observation underscore the need to eliminate the concept of wait and watch policy in asymptomatic AS and implant the early TAVR procedure strategy should be adopted. So 3 questions. Following etiological mechanism constitute the non-structural valve deterioration after TAVR or SAVR except AV calcification, patient prosthetic mismatch, paravalvular leak, malposition and recoil. Clearly, AV calcification is the structural valve deterioration, not the non-structural.
Crossing wire.
Second, following statement is not true about the results of the Partner 3 trial comparing TAVR versus SAVR in symptomatic severe AS at 5 years. Primary endpoint of death and stroke were similar. Higher valve endocarditis in TAVR group versus SAVR, higher atrial fibrillation rates in surgery, and similar pacemaker rates in TAVR versus surgery group. And answer there is not a higher valve endocarditis. Now, with the self-expanding, number D is wrong. That the higher pacemaker rate with the self-expanding TAVR compared to surgery, but in the Partner trial was no different. Question 3, following outcomes are true regarding the results of the early TAVR versus delayed AVR procedure in asymptomatic severe AS at 5 years, except delayed AVR group has higher death and stroke rates versus early TAVR group. Patient with acute valve syndrome had higher MACE rate. Conversion to delayed AVR occurred at a median of 3 years. Over 95% underwent AVR at 5 years in clinical surveillance. Clearly was, the median was about 11 months and so. So with that, we complete our presentation for today.
Okay, so thank you so much for the heart team for this super exciting case, and thank you for joining us today. Remember, this case will be archived this afternoon at ccclivecases.org. We do our structural heart life cases every month on the second Tuesday at 9 a.m. The next one will be August the 12th. See you then. Thank you so much.